Well, thank you very much for the opportunity to share some of our ideas with you. And I very often start with this Renoir to remind people that obesity is not necessarily an ugly thing, but what you can see with these patients, they have a sedentary lifestyle, they have visceral adiposity, and they're lying down because they need peritoneal dialysis because they're suffering with the complications of type 2 diabetes. So if we want to use surgery, how can we actually help these patients per se? So I'm going to start with a case report, one of my patients. This chap was 66 years old, and he had end-stage renal disease because of his type 2 diabetes. He needed peritoneal dialysis, and that's a list of the medication that he had on. And of course, we suffer with polypharmacy, so he's having lots of complications because of the drugs, which we had to give him because of the complications that he has suffered. We use this obesity staging score that we designed at King's College, and the way we think about obesity is very similar to the way you as surgeons have thought about cancer. You think in tumor node and metastases, and we actually think in the same way. We would argue that obesity is a little bit more complex, so we need a few more abbreviations, but we think through and alphabetically: airway, body mass index, cardiovascular disease, diabetes, economic, functional, gonadal, health status perceived and image, and then we classify it or stage it. 0 is normal, stage 1 is at risk of a disease, stage 2 is an established disease, and stage 3 is a complicated disease. Because just looking at somebody's body mass index is not very helpful. So if you look at the Irish front row, all of them have morbid obesity, but the risk of them developing type 2 diabetes is not very high, where somebody with a BMI maybe of 31 or 29 may have type 2 diabetes and suffer with the complications of obesity per se. So what I would like to do with my treatment, be that lifestyle pharmacotherapy or surgery, is to downstage a patient, exactly as you would have done with cancer. So if I have, for example, somebody with type 2 diabetes, I can use lifestyle treatment to downstage them from impaired fasting glycemia to normoglycemia. I can use pharmacotherapy such as GLP-1 therapy to downstage them from controlled diabetes to impaired fasting glycemia. Or I can use surgery to downstage somebody from uncontrolled diabetes to normoglycemia per se. So this is our chap, and this is where he was before the intervention. You can see airway normal, body mass index was about 40. He had paroxysmal atrial fibrillation. He had uncontrolled type 2 diabetes. And then after the intervention, this is him now. This is how we've actually been able to downstage him and actually improve the complications. So when I have an obesity clinic, I don't weigh people anymore. So the minute you actually understand that obesity doesn't have anything to do with weight, it is a systems disease, then we are able to actually understand how we're going to treat the disease. Far gone are the days when we worked in our diabetes clinics, when every nurse was running around and taking somebody's blood sugar when they came to clinic. We don't look at diabetes as a glucocentric disease. We actually look at it as a systems disease per se, and obesity is no different. So how did we achieve that? First of all, we used a treatment that was defined in the New England Journal, the look-ahead study. Now, just to remind you, this was 5,500 patients that were randomized between intensive intervention or usual care. For 10 years, these patients were followed. This study cost $250 million. And what it showed is that if we actually look at the blue line over here, if you actually make people eat less food and do more exercise, they lose weight, and over a 10-year period, you can maintain about 6% weight loss. The usual care group lost weight gradually as such. The intensive group actually had a lot of exercise, their physical fitness improved, and it was maintained for at least 4 years in this study. But when we looked at something that your mother and my mother have been telling us for many years, that if we just eat a little bit less and do a bit more exercise, we will live longer, it turned out that we were wrong. And that's why we use randomized controlled studies for. So beating people over the head, making them exercise, making them diet, makes no difference to their mortality, as was shown by the look-ahead study and the graph over here. So we actually can now move on and actually work out, what it is that we need to do with these patients. Now, these patients were type 2 diabetic to start with, so they were at pretty high risk to start. But, can we define that risk? What is the risk of somebody, actually having mortality or dying in the next 10 years? And again, from a surgical point of view, you look at this the whole time in cancer, and therefore are quite familiar with these concepts. But this is the risk of me dying in the next 10 years. So I've got about a risk of about, or rather the broken line over here, it's about 8% mortality in 10 years. Now, if I develop diabetes today, my risk will increase to about 11%. And the reason why the absolute risk increases so little is because we are so good at treating diabetes today. Once you put somebody on metformin, a statin, and an ACE inhibitor, you actually are very good at keeping the mortality at bay. However, if you develop albuminuria as a marker of renal damage, then suddenly your mortality jumps to about 28%. And if you develop both albuminuria and an impaired GFR, so renal impairment, then your mortality jumps to over 50%. And that is actually higher than most of the cancers that you deal with on a daily basis. So the mortality of these patients are very high. So what have we done and how could we have helped this gentleman? And he had a surgical procedure called vertical sleeve gastrectomy. And the reason why this operation is so good, because it actually uses the normal signals from the gut that signals how hungry you and I feel and how full we feel every day. So all this operation does is it basically puts the gut on turbocharge, and therefore where obese patients have a deficiency in their signaling system and making them feel satisfied after they've had a meal, now suddenly we enhance their satiety signals, and therefore we get the weight loss, etc. So what drives the satiety? This is some work of ours showing that GLP-1 is a gut hormone that we can see in the purple line here. Obese people lack, they have a functional deficiency of this hormone. This is a normal response of GLP-1 in lean patients. But after procedures such as a gastric bypass or a vertical sleeve gastrectomy, the lines are superimposable. You can see that this natural hormone is both elevated, about threefold elevated, but also the peak occurs earlier, and therefore it's consistent with what we hear people say is, doctor, I can eat the same food as the rest of the family, but when they eat off a dinner plate, I now only eat off a side plate, and I feel full. And because I feel full, I don't have to eat so much food, and because I don't eat so much food, I lose weight. But we actually were able to use functional MRI and to look inside the brain into the reward centers to see what happens after a surgery such as this. And a very important concept that obesity is a chronic and complex disease that is characterized by excess weight. We can see if patients are obese, but it's because of a brain dysfunction. We now understand that obesity is far more like a neurological disease than a metabolic disease. And that's shifting the organ of target. So therefore what we want to do if we have an operation is we want to change what actually happens in the brain. And here we have evidence that the reward centers in the brain are down-regulated after surgery, and therefore it is consistent with what we hear patients say again, is now I can walk past the cupboard, I don't have to open the cupboard because I'm not preoccupied with food anymore. But what's the long-term effect of surgery? Weight loss and weight loss maintenance. Now, as a physician, I can make anybody lose weight. I lock them in a room, I give them 2 liters of milk a day, multivitamins. I can make them lose a quarter of their body weight. But what I'm not able to do is when they come out, actually prevent them from becoming hungry and then eating more food. But surgery can do that. So it's the maintenance of weight, 25% weight loss at 10 and 20 years, that is really the remarkable achievement. But something else that surgery does that I cannot achieve with pharmacotherapy is the reduction in inflammation. So we know that obesity and many of its complications are driven predominantly by inflammation. But here you can see that we are able to actually use different procedures, bypass, banding as well as sleeve gastrectomy, to reduce inflammation not only in systemic but also specifically in the kidney. So if we are able to do that, reduce inflammation. We can reduce body mass index. On that panel, we can reduce glycemic control, or improve glycemic control, improve blood pressure because of the gut-kidney signaling. Then we can also reverse some of the damage that is done, as illustrated by albumin-creatinine ratio. So for the first time now, we can actually think of diabetes, which we always thought is a progressive disease. We now have had to come up with a definition for cure for diabetes after surgery, something that we never thought was possible. We're now actually looking at end organ damage of diabetes and how we can reverse that. Now, what we also have at UCD is probably one of the only functional animal models for bariatric surgery, both gastric bypass and sleeve gastrectomy. And the great thing is that the rats behave in exactly the same way as the humans do. So what we have here is blood glucoses in the black line, the sham-operated rats that run in glucoses of about 30 millimoles per liter. These are the ZDF rats. In the grey bar, these are the heterozygotes that represent normal, and in the red is the bypasses, where we're able to actually improve their glycemic control, but we also see that there's some relapse that occurs very similar to some of our humans that we can control. But the point that we're trying to make here is this is the difference that we see surgery can make to glycemia in this rat model. And of course, rats are really helpful because we can also histologically look at their kidneys, so we can use the rodent model to interrogate mechanisms that we can't see in humans. Of course, humans is a species of interest, but sometimes we cannot do the mechanistic research that we are able to do in rodents. So here we have the normal rat. You can see a normal glomerulus. Here you have the sham-operated rat, see the sclerosis, and on this side you have the bypass animal, where you can see you don't have complete restoration of the glomerulus, but a very significant improvement. And when we look further with inflammatory markers and immunohistochemistry, we can see it's predominantly because of the reduction in inflammation around the glomerulus that you are able to turn the clock back, having used surgery per se. We're now busy with a randomized controlled trial, and we're doing this in conjunction with our colleagues in Santiago in Chile, where we are randomizing patients who have type 2 diabetes and kidney damage to either gastric bypass, sleeve gastrectomy, or best medical care. And even as little as 5 years ago, people said it would be impossible to randomize patients between medicine and surgery. And in fact, we now have about 6 randomized controlled trials in metabolic surgery showing that surgery is superior to medicine within the randomized controlled trial setting. And of course, that is really what moves the needle per se. So I'm going to conclude at this point and say that if we summarize this, we can actually help patients who suffer with metabolic complications such as diabetes and diabetes complications by using a surgical technique that actually changes what happens in the brain. And if we can change what happens in the brain, make people feel more full, they will eat less food, and then we can harvest the benefits of that intervention. We can also use animal models to study the mechanisms, because it's true that not everybody would be eligible for surgery, not everybody would like to have surgery. So if we can actually understand how surgery works, we can not only refine the surgical techniques, but also come up with a combination of medical devices and pharmacotherapy that can mimic part of surgical benefit. So please just allow me to thank the people that I work with at UCD and the Dublin Academic Medical Centre. I'm very happy to take some questions. Thank you very much.
Thank you, Carol. And we asked you to stick to time, and you've done that perfectly, but there's an enormous amount of work. I'm sure you could talk to us for longer, and I think we'll get you back. But the mechanism is very interesting, and you worked with Francesco Rubino, and the duodenum is sort of a critically important organ, isn't it, as much as the pancreas?
Correct, absolutely. So we're actually looking at both in the Roux-en-Y gastric bypass, the biliopancreatic limb, which may be an important source of signal, both from bile acids, and we as endocrinologists are fascinated right now with the role of bile acids as an endocrine signaling system. But probably the most important driver of the combination of hormonal as well as neural signals from from the mid-gut. And what intrigued us is that the Roux-en-Y bypass and the sleeve gastrectomy almost give superimposable biochemical results. And it appears that with both of those treatments, we actually get food into the midgut much faster. And therefore, you have the gut hormones as well as vagal signaling. That seems very important.
Sure. It's very important, but yet in Ireland, we're not doing it.
Yeah, there's huge variation across Europe when it comes to penetrance of surgery. Ireland is probably one of the lowest right now. Countries that probably are the highest are places like Sweden. And I don't think anybody is going to accuse the Swedes of being, cavalier or, cowboys. So what they've been doing is they've just been doing it in a very systematic way. They have their classical big registries, the SORAG registry, and they have more than 9,000 patients now collected over the last couple of years. Well, they do 9,000 cases per year, actually, I should rather say. And Sweden, of course, have some of the lowest obesity rates. But they're doing it in a systematic way. They're working as clinician scientists, so they're actually capturing the data, learning from their experience. But it was driven by the surgeons and have done incredibly well.
And it's in the NHS. I mean, most UK hospitals have quite a large wing dedicated towards...
Yeah, and the National Institute of Clinical Excellence, NICE in the UK, who actually looked at randomized controlled trials, have now said that body mass index is not a deciding factor for the surgery. So we're not chasing kilograms, what we're chasing is patients' health. So therefore, they've reduced the body mass index.
Pancreas.
Correct, absolutely. So we're actually looking at both in the Roux-en-Y gastric bypass, the biliary pancreatic limb, which may be an important source of signal, both from bile acids, and we as endocrinologists are fascinated right now with the role of bile acids as an endocrine signaling system. But probably the most important driver of the combination of hormonal as well as neural signals from the midgut. And what intrigued us is that the Roux-en-Y bypass and the sleeve gastrectomy almost give superimposable biochemical results. And it appears that with both of those treatments, we actually get food into the midgut much faster. And therefore, you have the gut hormones as well as vagal signaling. That seems very important.
Sure. It's very important, but yet in Ireland, we're not doing it.
Yeah, there's huge variation across Europe when it comes to penetrance of surgery. Ireland is probably one of the lowest right now. Countries that probably are the highest are places like Sweden. And I don't think anybody is going to accuse the Swedes of being, cavalier or, cowboys. So what they've been doing is they've just been doing it in a very systematic way. They have their classical big registries, the SORAG registry, and they have more than 9,000 patients now collected over the last couple of years. Well, they do 9,000 cases per year, actually, I should rather say. And Sweden, of course, have some of the lowest obesity rates. But they're doing it to a body mass index of 30. And just to give you an idea, my body mass index is 30. So I would be eligible for a gastric bypass or a sleeve gastrectomy if my diabetes is uncontrolled, for example.
Sure. So I said it wasn't being done. That's not quite true. I mean, there's a few cases done in Loxtonstown every year. There's about 20 cases done.
Well, that was actually stopped for the last 2 years, and Donal O'Shea, and Justin Gagan are working very hard to get it reintroduced. But I'll get on my high horse just for a second. But if you draw a cartoon of somebody of color, or you hang an HIV tag around their neck and you make a joke, it's called hate speech. But it's perfectly okay to actually think that obese people are stupid and lazy, and to have them slip on a banana skin, and it's still very, very funny. So it's sort of the last bastion of discrimination, but that just illustrates our misunderstanding of the condition. We really still think, very smart people still think it's just because they should just push themselves away from the table. But I always say to the audience, I will challenge you as an audience and say, I will give you €1 million if you can hold your breath for 10 minutes. Okay? And all of you are smart enough to hold your breath, and all of you would be motivated enough by the money, but at some point at a minute or a minute and a half, your medulla oblongata will make you take another breath. So that's exactly what happens if we ask obese people, why don't you just eat a little bit less? They can do that for a period of a time, but at some point their hypothalamus, which sits, which is white matter, it's not grey matter, will make them eat food again. So unless we actually change the biology, and surgery is this perfect way of changing the biology, we will not be able to address the problem.
Okay. Mitchell.
Can I just make a point, is that there's a lot of this surgery going on in Irish people, not necessarily in this country. There's people flying to units in, private units in Birmingham, Brussels, to get your Ryanair flight out. You talk to them on the phone, they'll book your flight for you, go out to get your procedure done. Usually it's a laparoscopic banding, I think.
It's usually the weight loss, isn't it?
Hours later they wheel you onto the plane and send you home. And I know this because we get a lot of these patients coming for skin reduction, which is it's a resource issue, and that's why the government probably pulled the plug. And this is massively expensive, and not only from the obesity surgery, but from the aftermath of the obesity surgery. Like letting the balloon, the air of the Michelin Man, they get excess skin in their arms, their legs, their abdomen, their breasts, their face and neck, and they all want it removed at some point. And that's it. That's 5-6 operations. If you agree to do that at the public health service, it's hugely resource intensive.
That's true, and again, part of the problem was that people have been chasing kilograms, so they've actually been doing operations on people and say, you will change what you see in the mirror after this procedure. And what we actually see is as obesity treatment, it's pretty rubbish. So if you have appendicitis, you come into an operation and you leave the hospital, you still have appendicitis, you didn't have a great appendectomy. So if you have these operations with a BMI of 50 and you actually leave, 2 years later you have a BMI of 35, it wasn't a great treatment for obesity because you lose about 15 BMI points. But if you have a focus on, for example, diabetes, you come in on 100 units of insulin and you leave not requiring insulin with the normal fasting glycemia, that's where the shift has happened. And I think that's why, we are now no longer that interested in bariatric surgery, but what we're really interested in is metabolic surgery. How can we use surgery to make people healthier? And of course, then we actually are treating people with much lower BMIs who then don't have the excess skin afterwards. But it is true. The most expensive thing we do in healthcare is dialysis. It costs us about between 50 and 70,000 euro per year. So if we can stop people progressing onto dialysis, we've really made a difference as such. But then you have to treat people who are at risk of going onto dialysis. Not every obese person is going to develop a renal failure. Not even every diabetic is going to do that. So it's about risk management per se. But the costs are not insignificant, and that's why it's also important, as you outlined, that there's proper systems that look after these patients, and that they're not, go into the wild world and then come back without systems to look after them.
Mitchell.
Thanks very much for your talk. I was just interested to know, while this is a tremendous advance for type 2 diabetics with BMI greater than 30, how do you advise a patient with BMI 25 who also is type 2 diabetic? What do you learn from the BMIs over 30?
Sure.
You can extrapolate and advise patients with BMIs of 24, 25.
Yeah. So there are randomized controlled trials actually now looking at BMI 25 to 30 surgery versus medicine. And what we are seeing is that if you have type 2 diabetes, for example, you have a BMI of 33 and much of your diabetes is driven by insulin resistance because of your adiposity. If we reduce the adiposity, then your diabetes gets better a great deal. If you have a BMI of 25 and you have type 2 diabetes, then adiposity is not driving the diabetes. It's driven by insulin signaling or even poor insulin production from the pancreas. So surgery does make an improvement because we have the endogenous GLP-1 that comes in, but we don't see the same level of improvement in those much lower BMIs than we see in BMIs above 30-35%. So there is a balance. And of course, surgery doesn't come without risk. The mortality of bariatric surgery at the moment is about 0.2%, and that's a similar mortality to cholecystectomy or hip replacement. So surgery has come down dramatically. Typically, procedures take about 45 minutes. Patients go home 1 or 2 days after surgery. There's in Denmark a couple of cases, a couple of centers that do day case gastric bypass or day case sleeve gastrectomy. I think those guys probably took too many bravery pills in the morning, but I suspect these patients can be managed very quickly. They typically are 4 hours after extubation. We have them up and walking around the ward, because one of our biggest risks is, of course, DVTs and pulmonary embolisms. So they are eating, or they're at least drinking, immediately post surgery. So the enhanced recovery, of these patients are very interesting.
Okay, any other thoughts or comments? Or do you want to ask any questions?
No, it's what I think is what needs to happen is the shift. Thinking about metabolic surgery, thinking about operating on patients with diabetes rather than patients with obesity. Clearly, there will be exclusion criteria, and one could start with BMIs of 35. But many of the patients that actually come onto your theatre table now have BMIs over 35. I don't think that, but people always tell us you have to darken the door, when you actually even consider people for surgery. So the BMIs of 50 and 60, that's not where the burden of disease is. The burden of disease is at a much lower BMIs, and they are also the patients that would benefit most.
Okay, so we've heard from some of the consultants. Can we get some of the NCHDs or the undergraduates? Wild and Michael, what did you take from this presentation? Okay.
Different angles of the diabetes,
Okay.
I think it's very interesting after especially working with Justin Gagan in bariatric surgery and actually seeing the actual effects on patients. Like you said, it is quite expensive to do as a sleeve bypass, but just lowering medication and hospital visits, I guess, and GP visits on the long term does have a great outcome, I think, for the patients mentally and physically.
Yeah, and technically it's nice surgery, isn't it? Very standardised, very, it's very enjoyable to do, but it's all about the patient selection and the focused outcome. Jessica, have you any thoughts about this, or what did you take from Professor LaRue's talk?
I think it's really interesting that they're always burdened by such amounts of medication that to be able to take them off would be really interesting.
And the concept of the public health messages being wrong. I mean, losing weight is difficult, isn't it? But being fitter, or maybe exercising, or I think that's interesting. And then the last question is this going to be shut down? Is this a neurological problem, and that surgery is actually just a stepping stone until we work out the neuromodulator mechanisms? Is this?
Well, we think it's going to be not dissimilar to cardiac bypass surgery. So if we look at the 1980s, we had some pretty rubbish medication, Questran that we gave people with familial hypercholesterolemia, and we had coronary artery bypass grafting. And then in the 90s and in 2000, when we actually had medical devices such as stenting coming along and better pharmacotherapy, we were able to combine those. Now, it's still true that coronary artery bypass grafting is superior for especially in patients with type 2 diabetes, but the actual penetrance has changed by understanding the mechanism. You never say it's surgery or radiotherapy and chemotherapy. It's a combination of modalities that actually give the patient the best outcome.
Okay, well, excellent. So we're time up. So thank you, everyone. Thank you.
Thank you.
Would you stay with us?
Yeah. Thank you so much for the invitation.